Hello and welcome to this BayCare Clinic live seminar. We're here at Orthopedics and Sports Medicine BayCare Clinic in Manitowoc to get a better understanding of in-office orthopedic hand and wrist procedures. Thank you so much for joining us. Dr. Craig Olson is our guide today. Good evening, doctor. He performs orthopedic hand and wrist procedures in the office. He's board certified by the American Board of Orthopedic Surgery. This is an open conversation today. We invite you to type your questions and share any concerns you might have. Dr. Olson will do his best to answer those questions in real time. If we don't get to your question during the live stream, we'll definitely provide an answer at the end of the programming. Before we get started, as you can see through our use of this social platform, we're taking several precautions and following social distancing guidelines for our conversation today. I'm in one location, the doctor's in another. So I want to assure everyone that we are being safe. Having said all that, Dr. Olson, thank you again. The floor is yours.
Well, good. Thank you. It's my pleasure to be here. We're talking about office-based minor hand procedures today, but I just want to make it clear I've been in practice about 30 years, mainly knee and hip and shoulder joint replacements, but hand surgery's just been an area of enjoyment for me. And over the last, say, 15 years, I've really worked on changing what I can do to make it easier for patients. And the office-based surgery is really, where I've gone to. And really some of my patients are the ones that really have gotten me to make some of the changes I did so that I could do this in the office. The most common thing that we see with minor hand surgery is carpal tunnel. We also see ganglions, trigger fingers, decurvains, tendonitis, mucoid cysts, but carpal tunnel is the very common thing that people see. And if you say carpal tunnel on the street, most of the people say, oh yeah, I might have had it, or I need it. And that's been really enjoyable for me. So really a lot of the hand minor procedure things that I've done in my practice life really came through learning how to do carpal tunnel through a small incision and do it in the office in a way that a patient can tolerate that and have it comfortably done. So if we talk about carpal tunnel, really, what is it? First of all, the main nerve that really provides a good portion of the hand, really the thumb side of the hand to the ring finger, numbness in that area is generally due to the median nerve, which is one of three nerves to the hand, but that gets compressed with various conditions. Sometimes we don't even know why it's being compressed, but sometimes repetitive activities with work, typing, pregnancy, but the compression of that nerve becomes painful and swelling in the tunnel, and that's why they call it carpal tunnel. The swelling in the carpal tunnel is really what brings people to come in to say, hey, my hand is numb, I wake up at night, I have to shake it, it has a burning sensation. Then patients start talking about dropping things and constantly having wrist pain, and that's what really brings them in to see us. And so really, what's the problem? Is the nerve literally has to go through a tunnel on this end of the wrist and come into the hand. And there's a very large ligament that crosses between the muscle mass of the thumb and the muscle mass of the little finger. That ligament causes or forms a tunnel, which the nerve goes through. And really, when we talk about carpal tunnel treatment, there's many ways to do it. There's open, hospital, sometimes using a scope to do it. There's a thread wire technique. There's all these other techniques, but in the end, it's about the ligament on the top and its tightness on the nerve and somehow cutting that ligament. Let's see
So
what
this
that
is,
shows. Go ahead. Yeah.
jump in for a sec. So this is something we're proud to say we actually offer in office now. It's my understanding the traditional way is to do it in an OR or operating room, operating theater. But how big a deal is it that we can do this in office?
Well, number one, if you see these graphic pictures of a hand having surgery, that's way too big of an incision, but it does show some things. There's kind of a band that crosses the middle of the incision. That is the thick ligament that we want to cut. And you can see when you go to the next panel that they're actually cutting that ligament. And then in this last panel, you can see that the yellow nerve below is now freed with that being open. Now, do we have to make that big of an incision? No, that's the beauty of being able to do it in the office and use a smaller incision. So I got my hand here. Hopefully you can see it. I'm going to make the incision out with a pen. And there's, now how can we make that cut in the office and not have our patients, you know, in a lot of pain? We numb it all up first. And so how do we do that? Is we get down, we know that the median nerve starts down here in the wrist, and we actually put a little bit of numbing medicine with a shot right there. We usually freeze these spots with a freezy spray so that that pain of the shot is less. Then we do the second shot into the carpal tunnel itself. And then we also then numb up the incision. And then we leave our patients alone for about 15 minutes. Why? Because we want that medication to set up. So then even at that point, patients realize, hey, I feel my fingers and other things, but the areas where we have to work are going to be numb. So what we do is then the patient goes to a different room after we've numbed up the hand, we clean the hand, and then we lay out drapes and things so we can do the surgery. There's a nice YouTube video out there. If you want to watch it, you can find it on the BayCare website. But with that all being said, what we'll do is then we test this area where we made the incision. We actually poke it to see, hey, is that hurting? Patient's like, I don't feel that. So then we go ahead and proceed. We always have extra medication if we need it. Hardly ever have to use it. I can't remember using it in the last year or so. But what we do is then we make the smaller incision here, but then we, underneath the skin, we can find this ligament that you can see on the first panel, this white structure that crosses the incision. And we're trying to find that structure, and we're trying to get below it and above it. And once we get below it and above it and have it isolated, we have a tool that is almost like a seam ripper. Run it through. You can definitely hear it as it cuts the ligament, and we know it's cut. And patients can almost right at that point can tell that something's different, because now that pressure that was on the nerve is gone.
Okay, so that's fascinating stuff. So not only do you do in-office procedures for carpal tunnel, but I know at some point we're going to be talking about trigger finger and even ganglion cysts, correct?
Yes, yes, but hey, I'll go back to the carpal tunnel now that you got my mind going. The main thing is once it's done, 2 stitches, a bandage that people only wear for about 4 days. The stitches stay in for 2 weeks, but you can take care of your hand with soap and water. We encourage people to do normal activities using the common sense that if they do enough activity and they have pain, achiness, and soreness, you've done enough. You had carpal tunnel surgery, but each day you do more and more. The important thing is we want to get the wound to heal. But yes, your question is great. We do other minor hand procedures such as trigger finger. Trigger finger is kind of similar to carpal tunnel. It just happens in a different way with the bending of the finger. instead of having the nerve going through a tunnel, we actually know that the tendon of the finger that flexes has eyelets, almost like on a fishing rod, that the tendon has to pass through. Occasionally, the tendon gets swollen and then it can't actually pass through the eyelet. So it gets stuck and then the finger is locked down. And sometimes a patient has to unlock it. Generally, in the early course of that problem, we can do things like steroid injections and that can solve that. But generally, when a patient starts having to manually unlock their digit, it's not going to get better with a steroid injection. So again, what we do is we follow where the tendon travels, and I'll try to get my hand in a good position. But if it's your index finger, we just make a small incision here. And again, we do the same numbing process where we find the nerves ahead of the area we're going to work on, and we numb them with an injection here, and then in the incision. And again, we let the patient cool out for 15 minutes while we're getting everything ready. And then we get you over to the procedure room and test whether it's numb, do the cleaning that we need to do. And then we proceed. And what we do is we follow the tendon right to the eyelet that's tight around the tendon. And then we have a device again, like a seam ripper. I'm starting to sound like a seamstress, but it works great. It protects every other structure and it cuts that eyelet. And again, patients can almost, we ask them to move their finger after we've released it to see if they can sense the catching of the trigger finger. And, you know, most all the time, they don't feel any catching. And if they do, we carefully go back up and check it and make sure it's completely released, and we can, you know, release a little more if it needs to be released. But we have like a manual check where the patient can say, hey, it's not catching anymore. We can do thumbs, we can do all the fingers. So that's been an exciting thing. And I've only kind of learned that over the last 7-8 years since I've been doing the carpal tunnels in the office, and patients have been kind of saying, well, look, I got this problem, can you do it? So that's really led to all kinds of other problems. Here's kind of a rendition that's kind of showing what the surgery's like. Up in the upper left corner on panel A, it kind of shows the knife, you know, cutting the skin. I'd say that's approximately the size of the skin cut. It's usually about 1/2 inch in size. There's also ganglion cysts that sometimes is a fluid collection that can form many times on the volar side of the wrist, a lot of times on the thumb side, but occasionally on the back side they show up. We can also do those in the office. Basically the same strategy is numbing up the area and, you know, letting the patient get comfortable enough to where we can go and get that. But we've also done things like tendonitis of the thumb called de Quervain's tendonitis, which is a condition where the thumb is painful with moving and especially pinching. If you're, you know, pinching an item and having pain kind of in this area of the thumb, that's usually de Quervain's tendinopathy. Other conditions such as Dupuytren's contracture, where a finger is contracted and there's a band that's contracting that. We've been able to take care of that. Small mucoid cysts that people get just past their nail. You know, the office-based hand surgery has just opened up so many opportunities to do minor hand things in the office. We haven't seen issues with infection. We have not seen issues with people having pain during the procedure, and we've seen excellent recoveries after surgery. And it just encourages us to want to take care of more people this way because they're so pleased with the results and how it goes. They can drive to the office themselves. They don't have to get a driver because we're not going to sedate them. We allow them to use their hand to be able to drive home. Many people want to have the procedure late in the week on a Thursday or Friday. they want to go back to work on Monday, and we let them go back to work. So we really don't try to restrict people at all. I've had some patients that have the procedure and leave the office and go right back to work. So, you know, I mean, I'm not trying to tell people what they should or shouldn't do, but what I've learned is I really don't have restrictions on their activities and, you know, what they think they can do, and I basically let them do things.
Doctor, let's take a few steps back. You had mentioned a couple of things that I wanted to follow up on, but I wanted you to finish your thoughts.
Okay.
We had talked about the fact that you don't sedate patients for these in-office procedures, and that was actually a question that I was kind of waiting to ask. I mean, if somebody has a fear of needles or is just ridiculously nervous,
Yes.
you don't offer any sedation, then what do you do? How do you handle those patients?
We have given some people some kind of a oral sedative, such as a Valium or something like that prior to the procedure. And we have had patients that are extremely phobic to needles and things of that nature. And we've addressed that way. And those patients have done very well. You know, occasionally there's a patient, and sometimes it's because they have two things they want me to care for. Occasionally we do some of those patients in the operating room. So it's not like we wouldn't do it in the operating room, but I would say like 98% of the patients, once they kind of know what's available to them, they want to do it in the office. And, you know, they come back and have other procedures done. And, you know, it's nice to hear from them when, you know, years later, they come back and they say, well, you're better at it now. This was even easier. You know, so you know, sometimes a sideways compliment, we take them all. But, you know, by and large, that's what we've seen and what's made this procedure enjoyable to do, whether it's carpal tunnel or any of these other minor procedures.
Okay, so obviously in-office procedures, it's not a brand spanking new idea, but it also hasn't been, I don't know that you could call it traditional just yet. So somewhere along the lines, something had to have changed in the tradition and culture in orthopedics for this to have become something that's fairly common or at least growing. Can you talk a little bit about that? I mean, you've been in the business for a little while now and seen some things. So
yeah, I mean, about 20 years ago or even more, I saw this procedure with Dr. Strickland in Indiana, and he had the device that really made it easy to do the procedure, and he was doing it in the office. And frankly, he was saying that he just wasn't getting a lot of traction, you know, with getting other providers to try to do this in the office. But it did catch on. And I mean, in Canada, you can't have it done any other way. And I had a hand surgeon friend in Ottawa that essentially, you know, about 10 or 12 years ago was, you know, saying, look, I'm doing them in the office, you know. So I looked that up, and frankly, I had some patients that really would say things like, I can't really do this right now. I'm just going to have to suffer. I'm a single mom. You know, I got to take care of the kids and work. And, you know, it was patients like that when I was able to say, well, I believe I can do this in the office and we won't restrict you. We'll let you get right back to work and do the stuff you need to do. These pioneer patients who were willing to try it really were the patients that really got me started. And, you know, I was kind of doing the same technique in the operating room. And my anesthesiologist at the time said, you know, we can do a simple block. I'll show you how to do this block and numb them up. And, you know, after he showed me how to do that, a few years later, he said, you're taking me out of business. You know, you're doing all these blocks and doing the procedures in the office. But he's a good-hearted gentleman, and he taught me how to do it. And so, it's just been one of those things where early on there were patients that kind of had special needs to say, I can't really do it right now. I really got to do it. And these patients kind of pushed me over the edge to pursue that. So now it's a little more common. There's other techniques that people are doing in the office. And I'm kind of staying with the technique that I know how to do. There's other, fancier, I would call them more challenging ways to do the procedure. But this procedure has been simple, and patients really are very pleased with, their results. And they heal up quick. They get back to the stuff they want to do. So I'm almost feeling like some of the more fancy methods we're competing with those methods doing it in the office, and our office-based procedure is significantly less expensive. So if
that brings me
to pay, that's going to save patients, quite a bit with this procedure. I mean, it's probably about a third of the traditional hospital expense to do it in the office. And depending on certain insurance companies, I'm sure it's either a little bit more or a little bit less. But
and that leads right into my next question then. In-office hand procedures, are they all covered by insurance? Is that an issue?
I think I'm getting that. There's a little bit of reverberation, but what you were asking, are they covered? We have not seen a case not get covered. So even workman's comp cases are covered. All major insurances have actually been thankful that we're doing it the way we're doing it. And a few insurance companies have asked if we could do more of that procedure, because the insurance companies sometimes are paying, the big bulk of the expense. And so, we all hear how, healthcare is so expensive. And I'm sure, people also know that insurance companies are always looking for something, that can solve the problem the same and be less expensive. But I would just say, I don't even believe that. I think that the method has shown that it's actually better. Patients tolerate it better. Their response to how they do with it is, that response is better. So, this is one of those rare things that we found something cheaper, and guess what? It's better. So, I mean, I really enjoy it. I mean, I look forward to the office-based cases because I know patients are scared. That's normal. My job to tell them, look, and unfortunately I use some humor, and some people get the humor, some people don't. But, when they realize they don't get the humor, then I kind of get a little more serious and tell them the truth. But we just really, once patients get through it and they're leaving the office with their hand bandaged, they are amazed that they did it. And they really it wasn't that bad. The shots was the part that they didn't like the most. And they really said that wasn't bad. So
Doctor,
I really enjoyed it.
Let's talk a little bit about recovery time after an in-office hand or wrist procedure. How does that compare to being in the OR and undergoing a similar procedure? Does one offer quicker recovery time than the other?
No, it's a good question, because as surgeons, we're kind of creatures of a habit that we know works. So, many people came out in training. When I was doing training, we splinted the hand in the functional position with a splint for 6 weeks after a carpal tunnel. I still see patients that had one side done and, they were splinted for 4 to 6 weeks. And, I have nothing against that. And I'm not really here to say, oh, my way heals faster. But the main thing I'm going to say is my incision is smaller. The other thing is we know that this callousy skin of the palm of our hand, like the bottom of our foot, is amazing in its ability to heal. It's literally built to heal faster. So those incisions seem to heal very nicely and faster because they're in an area of the hand that, doesn't move the same way as the wrist crease. And when the incision goes through a wrist crease, or any crease for that matter, it's kind of a little more difficult. So I think there are some advantages that tell us that it can heal faster. And frankly, the people that were the pioneers that said, hey, I need this done, I'm really busy, I can't, do this, that, or the other thing, like have my hand in a splint for 6 weeks because I got 3 little kids. I mean, I kind of told them, hey, keep the bandage on, but do everything you need to do. And those patients would come back and report to me, I was fine, and their incision was fine. So over time, I just continued to, let my restrictions after surgery become fairly lax to the point, do whatever you want, just make sure if your wrist and hand is in some pain, ask yourself, hey, what have I been doing? Maybe I should give it a little rest. So I've let people use common sense, and I really have not, been burned by letting people do that. And, frankly, when they are so happy that they got back to normal activities, after a while, you almost have to say, I guess I can make it easier and easier. Occasionally, we have some people that have a little bit of a healing issue where the wound doesn't completely close in the 2 weeks. But all of them once we take the stitches out at 2 weeks and have them do some basic wound care, they heal up. We have not seen problems with that. And knock on wood, haven't seen an infection in a long, long time. And I think probably over the last, I was looking at it, 8 years, we've done about 600 minor hand cases, and the majority of those are carpal tunnels.
So doctor,
yeah.
If I can interject really quickly,
yes.
you've done enough of these that you must have had a sense for maybe a theme with regard to what people ask when they inquire about these types of in-office procedures. Can you share with us tonight maybe 2 of the most common questions or misconceptions that you help clear up among your patients as regards to in-office hand and wrist procedures?
Yeah, the number one is, patients, unless they know another patient that I've taken care of, patients are going to say, can I really do it? And then, we've had patients that are willing to take phone calls from other patients to tell them their experience. But I haven't done that now for a couple of years now, but occasionally that's a backup plan if I need it. But that's the number one, oh, well, I make it. And, sometimes I'm a little facetious. We haven't had to call an ambulance in, the last couple of cases, but we've never called an ambulance ever for any of these patients. They've all done well. They've all made it through. And it's really my job to tell them truthfully, we're not here to hurt you. We're here to help you. And we've maximized everything that we can do to make that pain the least. And again, patients, after they've asked that question, had the procedure and, are leaving the office are like, I didn't believe it. So, so that's probably number one. And then number 2 is what's my downtime? How much downtime? I'm like, well, I'm not going to make you do bed rest, for a week. So get up and, drive home and start doing stuff. And so really my, answer to the downtime is common sense. Do realize you had surgery, but you can still do minor things. You can take care of, household things or, prepare things in the kitchen and do minor jobs. And some people, they just say, well, I got to go back to work. I said, use common sense, don't overdo it. The number one thing is making sure your wound heals. So if you're doing a lot of work and, now your wound is draining and stuff, well, hey, maybe the writing's on the wall that this isn't going to work, but that rarely happens. So those are the two number one things. Doc, can I really do an office procedure? Yes, you can. You will do fine. And number two, am I going to be laid out? How long am I going to be off work? I kind of say it's really up to you. I'll do, if you need to go to work tomorrow or today, we'll write the note. And if your work will allow you to do it, and, sometimes I got to ask about, well, what is the work? And, is your hand going to be submerged in dirty, solutions? Well, maybe that's not going to work. But in general, with a good clean dressing and leave it on for 4 days, we have not seen any problems.
Okay, doctor, your presentation is still on ganglion cysts. So we've talked about carpal tunnel, trigger finger, ganglion cyst. Was there anything else in the presentation you wanted to touch on? Were there any last thoughts you wanted to share? Do we still have a couple of pages left in your presentation?
Sure. Yeah, I mean, getting to the ganglion cyst, that's probably another, common hand problem. They can turn up anywhere. I mean, this shows ganglions, down at the wrist and the finger, at the tip of the finger, called a mucoid cyst. And we take care of all of those types of ganglions very similar way. We isolate the location where they are. We do the appropriate numbing to locate that area. And then we try to use the smallest incision we can to get it out and make sure we get it out in a way that doesn't come back.
Okay.
So another frequent treatment that does very well with this same process.
Okay.
Let's just see. Oh, yep, there's a nice ganglion. They're getting it out. That's a very good image. So, my thought is the incision shown here to get the ganglion out. Sometimes I can actually reduce that incision to be a little bit smaller than the overall size of the ganglion. And in some ways that actually really helps the process, because as we go around the cyst, which is almost like this knotted up ball of fluid, the smaller incision actually, as you kind of get it to lift out, actually almost delivers the ganglion out. I mean, maybe that's a little too much knowledge for people out there thinking about how the surgery will be. But the smaller incision generally can help get that ganglion to completely come out, so that then it's easier for us to really take care of it. So another fun procedure for me. Patients really like the fact that they can get rid of an unsightly bump that's bothered them and caused them some pain. And we can certainly do that in the office. Should I check on the next slide? Are there any questions?
Go ahead and check on the next slide. There we go. Yeah.
Oh my God, there's a lot of words on this slide. Okay. But we'll go through them because
the high points. The high points.
Hey, it's a smaller incision. It takes us, 5 to 10 minutes for a carpal tunnel to take care of it. Some procedures take a little longer. We can get people scheduled into an office, 1 to 2 weeks, lower cost. You can drive to and from the procedure on your own. You can return to work the next day if you so desire. We have many patients that do that. It's definitely a local regional block where we're just blocking the area that needs it. So you really don't have to be exposed to general anesthesia. And I think a lot of patients are sensitive to having more medicines than they need. Small incision, no COVID test is required, but I will wear a mask when I'm doing it. And we will do all COVID appropriate protocols to be protective. And the recovery for me, I see people at 2 weeks that really are fully recovered. So 8 weeks, sure, there's probably a few patients that took longer, but I would say 90% of the patients at 2 weeks are basically saying, yeah, maybe opening a fresh mayonnaise jar, I'm not so good at that, but everything else they're back to doing. So yeah, it's been great to share this information.
Okay. Doctor, do you have any last thoughts for our viewers?
you have these problems, I'm happy to help. I really
Okay.
enjoy the work. It's fun. And the more fun is when the patients come back and they're pleased with their results. That's what really, keeps us working and wanting to care for patients. So we really love that.
Well,
Awesome.
Thank you, Dr. Olson, for your time and your insights. And thank you, everyone, for joining us. We'll continue to answer your questions online after this live stream concludes. If you want to learn more about how Orthopedics and Sports Medicine BayCare Clinic in Manitowoc treats orthopedic hand and wrist conditions in office, visit us by clicking on the link in the post below or call Orthopedics and Sports Medicine BayCare Clinic in Manitowoc at 877-618-6678. We thank you for joining us. Take care of
And we
yourself.
can do it in Kakana as well. So that's a new location for us. So we're very excited about offering that in Kakana. Cool.
Thank you.
Thank you.